an associate professor at the University of Cincinnati. Thank you very much for the invitation today to talk about hepatic vascular interventions. Talking about hepatic vessels and the role of interventional radiologists in helping our multidisciplinary team in managing that. So it's basically another job for the interventional oncologist. I'll explain why in a minute. Do not have any conflicts of interest related to this topic. So an interventional oncologist, we do manage a lot of cancers in the liver and treatments. However, we work in a multidisciplinary approach with our oncologist team and transplant teams. And yes, this is actually a slide. It's not that the computer went bad. However, a lot of times when we have our computers or PCs, they go bad, we need a fix. And the same thing for the liver. When things go bad, we need the interventional radiologist to come and fix it. A lot of times, many hours later down the road, and a lot of interventions, and then finally the liver is up and running. So without further ado, we're going to start talking about hepatic arteries. So basically, there's a big role for interventional radiologists to manage hepatic arterial problems in the liver. And our transplant team, a lot of patients we're going to see today, the patients had cancer and eventually got a transplant. However, our transplant team comes to us as, hey, your role is not completed yet or not done, we need your help. And these are going to be examples of that. So our role in hepatic arteries. So I'd like to give examples that makes it easier to understand. 46-year-old status post-liver transplant. Yes, the patient had SCC, got transplanted. However, after the transplant, developed refractory ascites requiring paracentesis. And then basically in those patients, we do a lot of extensive workup to try to find the etiology, including heart pressures, liver biopsies to rule out rejections or bad livers, hepatic venograms or MRVs to see if there is any hepatic venous stenosis or portal vein stenosis. However, we get quite a decent number of patients where there is really no clear understanding or clear etiology. And that's where the portal hyperperfusion came into play, where we identified, we're not talking about portal hypertension as much as we're talking about portal hyperperfusion, where we identified that there's a lot of those patients who have no identifiable cause or etiology for the ascites, that if we have elevated resistant indices and a discrepancy between the size of the liver and the recipient spleen, i.e. that the patient has a huge spleen, that they can have high portal flows washing adenosine and affecting the hepatic arteries. And on those patients, we do this extensive work that I talked about. If everything is negative, the patient does have a big spleen, and the RIs on the ultrasound is a little bit on the high side, then we consider that it could be portal hyperperfusion. This patient did have elevated 0.85, sometimes up to 0.9. So what we do is usually we do a hepatic arteriogram. We try to keep the pressure injection the same and the injection rate the same for this reason. So basically, if you look here, you can see there's a huge spleen and there's barely filling of the hepatic artery. So we do a proximal splenic artery embolization. Usually we use a plug to do that. And now you can actually clearly see that there is a better filling of the hepatic arteries. And the distal splenic flow still is maintained because it's a proximal embolization. However, now this is exactly the same injection rate that we did on the first slide, where you can actually, on this one, you can barely see that the hepatic arteries are filling, but exactly the same injection rate immediately. And we've had patients where the hepatic arteries actually replaced off the SMA, and still we would see the same phenomenon. So it's not as healed as much as it's portal hyperperfusion. And this patient actually did very well, and his ascite is resolved. However, at the end of the angiogram here, you can see that there is a little bit of a kink and a stenosis there. But at that time, the ultrasounds were not that significant. We told the transplant team it could be now because there's better flow. We'll see what happens down the road. So ascite is improved. However, 3 months later, we suddenly found a decreased drop in the signals on the hepatic arteries with the follow-up ultrasound in 3 months. And we thought, the stenosis is now significant, could be pending the thrombose. So basically, we actually brought that patient. The stenosis was significant and very tight. And actually, we stented open, and the RI significantly improved after that. So I picked this patient specifically because he had 2 problems for one. And then this is like the improvement in the flows after that. This is another patient also a transplant liver and refractory ascites. We do all the full workup, including the hepatic venograms, the biopsy. Patient does have a big spleen. And this is like, I like to show this case because you can barely see any filling of the hepatic arteries. And after we do the proximal splenic embolization on the right side, you can see it. This is exactly the same injection rate. And now you can see the hepatic arteries are very better perfused after the proximal splenic embolization, and then the ascites is actually resolved. This is another role for us, a 35-year-old status post-liver transplant, very complicated with hepatic artery thrombosis. However, they took the patient multiple times to the OR. However, after that, there was a decrease again in the indices in the hepatic artery. You can see the flows there, and you can see that there's two clips that are actually pinching the hepatic artery and causing severe stenosis there. On the hepatic arteriogram, it's not that significant because it's more of an anteroposterior crush than a cranial-caudal, so you don't see it as much, but in the obliques it was better seen. And now you can see after we grafted it, we opened it, and it actually went very well. This is another patient. Actually, this is an MVC accident, so it's not a liver cancer or liver transplant patient. However, this patient had a complete transection of his liver, like complete injury of his liver, transversed through the left and the right hepatic lobes to the extent that it affected all the bile ducts, the portal veins, hepatic arteries, and our transplant team got involved with this, that we are, they're going to have to transplant the patient because the patient was in liver failure. However, they said, well, let's see what IR can do with their magic there. And then basically there was a biloma, we trained it, the RCP went in, but they found that all the bile leaks were not communicating, just central filling, but nothing peripheral. And then there was also a pseudoaneurysm in the hepatic artery. So we brought the patient. First, we did an angiogram just to knock this one out of the ballpark. You can see the left hepatic is injured. However, there's a pseudoaneurysm. So we decided to coil embolize the pseudoaneurysm. After we're done. So we maintain flow to the hepatic artery, fix that. And then we had a very complex advanced intervention on the bile ducts because they were like all transected except one bile duct, which is the right posterior bile duct. So we stuck the right anterior and right posterior and the left. We were able to only get down in the right posterior, so we put a balloon and basically we stuck it percutaneously to get into the bile duct and then use this. I have actually a diagram here that shows it better, where because there's no communication between one bile duct system to the common bile duct, we actually used the balloon. I got it through and through access from the disconnected biliary duct system into the other duct system. And then through that, we actually put a balloon in, sutured the wire to the balloon outside the body and just pushed the balloon down over the wire, thus pulling this wire through, and this way we were able to get access into the common bile duct from both bile duct system. We did the same thing from the left bile duct. So we're able to connect all three bile duct systems into the common bile duct, considering that the two of them were completely disengaged. There was also, this is not a portal venogram, this is injection through the bile ducts, because during the ARCP they told us we saw a lot of venous bleeding through the common bile ducts. So they were also transected. So we actually used a modified biliary drain where we put no side holes across the portal vein injury, so this way we tamponed out it, and actually the bleeding actually stopped as well. The patient's surprising liver functions became back to normal, completely normalized, bile count, even the bile leak dropped from 700 to 50 mLs. So we basically fixed all the hepatic arteries, portal veins, and the bile ducts in this patient, and surprisingly, the patient did not need a liver transplant. It's really an interesting case where we're working with our transplant team that they identify what we can do and ask for the help. Another patient with, patient was seeing transplant because the patient had chronic pancreatitis and some liver disease. However, our transplant team called us, is like, oh, do you have an FCC patient? It's like, no, we have this big problem, this humongous pseudoaneurysm. The patient came with a pulsatile epigastric mass. Can you help us fix it? And was actually off the replaced hepatic artery of the SMA. And then not only that, but there was also a small vessel arising of the SMA posteriorly that also connects to the pseudoaneurysm. So this was the initial angiogram. You can see this huge pseudoaneurysm there. The problem is the hepatic artery is the main feeder of the liver, so we decided to stent graft that. But then we found some leak because of filling from that vessel that comes from inferiorly more cephalad. So we actually had to coil embolize that to shut down the endoleak, and then this was the ventral flow where there was a stent graft across the hepatic artery. So actually it worked pretty well. So shifting gears to the portal vein, and we have a huge role in those liver patients for portal vein, and I'm not going to go over the anatomy, but it's very important. I'm having the slide is to talk about. It's very important to understand the portal vein reconstruction. Read your transplant. For me, it's very important to read the transplant op note and talk to the transplant team to understand exactly what they did. Usually the flows in the portal veins normalizes after a few days. We keep that in mind, so we don't intervene immediately, as long as there's relatively okay flow. Portal vein stenosis, we find there's an abnormal flow in those, and this is an example where post-liver transplant ascites, worsening liver function, and we did a transtract liver biopsy, normal hepatic venograms, and the biopsy was fine. However, during the workup on the MRV, we found the portal vein stenosis, and here you can see there's huge shunts that are stealing blood away from the transplanted liver, and not only that, but it's actually accentuated because of the portal vein stenosis. So we put a stent in that, and actually the site is completely resolved, and the flows remain patent for many years. This is another patient that was liver transplant, also had ascites, and you can see there's severe portal vein stenosis on the images on the axial and coronal CT there, and then it doesn't look that bad on the portal venogram just because of the discrepancy in the size, also because it's more of an anteroposterior compression. However, we put a stent graft in it, and actually we use on this one a Vital, and actually we use Vital stent because the uncover does not gel off the splenic and the SMA, and we've been using it for many years. And actually, this is a 2-year follow-up on this patient. Patient did very well. His ascites is completely resolved, and the stent remained open. So 2-year follow-up was fine, and then ascites resolved, no recurrence. However, 5 years later, we noticed something, that the patient had this big, I don't know if you can see my arrow, but there is on the bottom left image, there is a big shunt between the SMA and the IVC. And also that increased in size over 5 years, and also there is rectal varices through the IMA, the bottom right image, that actually also increased, the patient presenting with some rectal bleeding. We also, the patient developed SMV thrombosis below the stent. So it looks like those two shunts were stealing blood away from the liver and the portal vein. So we brought back the patient. We actually got in. We did some thrombectomy and removed some clots. You can see the clots here at the SMV. But then we got into the IV, and then you can see this huge shunt into the rectal varices that the patient also had bleeding from them. So we actually embolized that shunt. This is the image where you can see the shunting into the internal iliac veins through the rectal varices. So we coil embolized that, and then this is the big shunt. So this is through the portal vein into the SMV, into the shunt that connects to the IVC that's filling cephalite there. So basically we put in a plug, and we embolized that, and this was the final image where the plug is, there's no more flow, there's no more filling of the IVC, and we did some thrombectomy and removed some chronic clot from there, and then this was the final image where you had excellent flow through the portal vein after embolizing those shunts. Now we had better hepatopetal flow versus it was hepatofugal away from the liver because of those two big shunts, and it actually improved. Portal vein thrombosis also can be a problem that we face on those patients, and basically this is a patient who had chronic portal vein thrombosis, and basically our transplant team now likes us to recanalize portal veins so they can do an anatomical anastomosis through their transplant. So as you can see here, there's no more portal vein, there's only cavernous transformation, and there's this clot also into the splenic vein, the subacute chronic. So, and you can see here on the coronal, there is no portal vein, there's big, huge shunts there. We got through the splenic vein, and you can see this huge shunts, no portal vein again, and all this filling the coronary vein. We're just injecting the SMV here. So we're able to find that where the black hair is, this very tiny hairline that is the remnant of the portal vein. We recanalize them, put the tips in, and then basically we open up the portal vein, and then after we bring the patient back at 1 month's follow-up just to fine-tune it, touch it with a balloon or something, and then basically if it stays open for a few months, then they can transplant the patient. We actually initially were shy of patients with a splenectomy. Now we're even recanalizing chronic portal vein thrombosis, even in patients who have a splenectomy through a transhepatic route, where once you stick the liver, you can find those very fine, feathery-like streaks of portal vein, and if you use a O1A wire like a nitrix, you can recanalize retrograde into the main portal vein, get access into that chronically thrombosed portal vein, angioplasty, open up to a bigger caliber, and then put the tips in. This is another patient with the cirrhosis, bleeding varices, same story. There is no As you can see, there is no portal vein. We go transplantic. Again, there's no portal vein there. Actually, in these patients, and we did a few of them, we were actually able to recanalize, keep recanalizing retrograde through the portal vein, all the way through the hepatic parenchyma into the hepatic vein itself, and then we can actually snare the wire to obtain through access through the IJ. So actually do a needleless tips where we basically do not use a needle at all to put the tips, and we just recanalize our way backwards from the spleen through the portal vein, and then we never use a needle. We've done quite a handful of those patients. Actually, Brooks works pretty well until the final image where the portal vein is open and the tips is actually flowing very well. And now you can see that very tiny portal vein that can barely non-existent. Now see how big it is and filling very well. So we actually had excellent flow there, and that's the main portal vein there. And this they can use this portal vein to anastomose for the transplanted liver. Shifting gears to the IVC, again, my message here is that I have to always review the op note for the IVC reconstruction or the hepatic vein anatomy. Read the op notes, talk to our surgeons to understand the anatomy, because it's very important, not just the ultrasound, but the ultrasound has a major role. So I want to talk about, we use the Cine MRI or MRV, which actually we found very extremely useful, where it actually helps us to really evaluate the donor and the hepatic veins, with donor IVC and hepatic veins to rule out any stenosis. And actually it can be performed without contrast, so it can maintain the renal function. This is a patient here, just 5 days post-liver transplant, and when we see this typical scenario, we know that there is a IVC stenosis. Patient developed liver failure, renal failure, because there's no outflow from the liver or their kidneys. There's no venous return, so the patient is hypotensive and needs pressors to maintain the blood pressure. Massive lower extremity swelling. Again, there's no venous outflow from their lower extremities. The venous hypertension in the liver causes pleural effusion and ascites as well. And you can see this very tiny white dot between those clips is basically where the red arrow is. That's the remnant IVC. So it's really extremely severely stenotic. And you can see here the coronal, it's barely filling there. It's very tiny IVC there. It's 5 days out. We were always very skeptical to intervene on just a 5-day-old anastomosis. However, we discovered that if you go gradual with smaller balloons and work your way up, it can be safely done even for such a short period from the operative, just fresh out of the operation. The green was 18. We injected hepatic veins. They were completely static. They were not flowing, hence the liver failure. And then basically we slowly worked our way up over some time with balloons to get it open, and then eventually put a stent to keep it open, and the gradient dropped. All the clinical problems completely resolved after this. This is a 3-month follow-up, and keep showing that the stent is completely open. And this was before and after. We can see the liver now looks much healthier, and the congestion has resolved. And this is the same thing. You can see the periportal halo and congestion all completely resolved. And this is a 7-year follow-up. These actually stents, because they're big size, they maintain patency very well. We use the ones with bigger interstices to maintain patency of the hepatic veins. IVC thrombosis, this patient actually developed complete clot in the IVC. What we do is, now we don't do thrombolysis much anymore. We actually do thrombectomies, because our thrombectomy devices have significantly improved in the past many years. So basically we go in, we do a thrombectomy, and then angioplasty, and we drop a stent in, and we had excellent flow after that. And this is the follow-up CT scan. Hepatic veins, this is a patient with 38-year-old females with PSC, got a transplant. However, had right pleural effusion and ascites, and then we discovered that there is a stenosis. There's also congestion about the portal veins, and then this, you can see here, there's barely, you can barely see the hepatic vein anastomosis there, severely stenotic. So there were multiple veins that are stenotic, as you can see on this vein here. At least we discovered that if you angioplasty and stent only 2, you can actually resolve the ascites and effusion. So basically we put 2 stents in and manage your stent in the IVC to keep them all open. And you can see here that this is the middle hepatic, it's flowing very well, and the right hepatic is actually flowing excellent, and the IVC is actually flowing very well there. And this is the follow-up CT, all the stents are open, and ascites and effusion and liver functions improved, completely resolved. This is another patient, a bit more complicated. She had ascites and pleural effusion. You can see there's severe stenosis of the right hepatic vein. We actually brought the patient back, angioplasted it, and stent grafted, and then you can see the stent here. Sorry, it's just stented it, not stent graft, stented it, and it's actually remained open. However, 4 years later, the patient developed a recurrent ascites and effusion and facial swelling. during the workup, we found, oh, the portal vein is completely thrombosed. There's no portal flow. So basically what we did, and this is the MRV where you can see complete thrombosis of the portal vein. And then when we try to access the right IG, we find the patient completely stenosed, hence the facial swelling. So we recanalized the central veins, got into the hepatic veins, made sure that the hepatic vein stent is actually opened 4 years later, but then we were able to look at the middle hepatic vein because that's what we're going to use for the tips to stay away from that stent that exists. And as you can see here, there is no flow in the main portal vein because of the clots. We did a thrombectomy and eventually put a tips in to maintain patency of the vein itself. And you can see how the portal vein is filling and the SMV and the IMV there. And actually, after we're done, you can see all the hepatic veins are widely opened. So basically, we did not jail any of the hepatic veins. So this patient, and then we angioplasty the central vein to maintain recanalization. And we actually, you can see both the brachiocephalus and SVC are now widely patent where they were completely occluded. So the patient got 2 for 1. So this is a patient where developed hepatic vein stenosis, and it doesn't rule out that 4 or 5 years later you can develop a recurrence, but from a different etiology. And it was 3 months follow-up. The portal vein had excellent flow, and 10 years follow-up. Now this patient's been with me for 10 years. She has excellent flow. This is another patient with severe hepatic encephalopathy after liver transplant, and you can see that it's huge. It was measured about up to 5.5 or 6 centimeters, so it's really huge. And the patient became very encephalopathic after transplant. So what we did was we actually got antegrade access, put a huge balloon I think about 3 centimeters or more, and we put multiple fogaries, retrograde, and also 2 implants or plugs. The biggest one we did, we inflated the balloon to achieve stasis, and then we injected glue that got caught on the plugs, and we completed thrombosis, and the hepatic encephalopathy completely resolved. So to summarize, interventional radiology has a major role, not only in oncology, but also in treating complications related to hepatic vasculature that affects patients' outcomes. We have a major role in the multidisciplinary team, including our transplant team, oncologists, hepatologists, where we really affect the patient's outcomes, and working as part of the multidisciplinary team has major advantages on patients' prognosis and outcomes. Your transplant teams needs your interventional oncology skills and the non-interventional oncology skills and support. And as we always say, if it's broken, IR can fix it. Thank you very much. I appreciate it, and have a good day.